So today we will be discussing about important update on acute pulmonary embolism. So this is the new guidelines that has come in 2026 by the American Heart Association. So this is a very important changes and there is a drastic changes compared to the previous guidelines. So today in this video we will be just discussing about how to diagnose and what is the changes in risk stratification that has been made. So the diagnostic challenge is that the prompt diagnosis is critical, but symptoms like pleuritic chest pain and dyspnea are non-specific. So the patient coming to ER with a pleuritic chest pain and dyspnea has a lot of differential diagnosis. So it can be related to a pneumonia, parapneumonic effusion, or a pleural effusion, or this pleuritic chest pain and cardiac chest pain can be confusing in ER, and patient won't be conscious enough or very alert enough to tell you that what kind of pain he has, and so much confusion happens because any patient presents with ER will be coming mostly with the complaints of pleuritic chest pain and dyspnea. So this is a alarming uh, problem with the pulmonary embolism. Usually it is missed out. So less than 10 percentage of patients are being diagnosed with pulmonary embolism and are eventually diagnosed properly and given proper management. So this is a very less number. That is why this diagnosis guidelines have made so that nobody is missed with pulmonary embolism. And first thing this video will be speaking is suspect and detect. Whom do we suspect? Whom do we detect? Clinical evaluation is very important, and as we know, history and physical examination is very important in emergency to rule out pulmonary embolism. So anybody who comes with chest pain and dyspnea, tachycardia, tachypnea, with all the clinical signs we know and sudden worsening of symptoms, with all the risk factors for pulmonary embolism, we will always take the history, and we also have to do a physical examination. And history and physical examination again will not rule out pulmonary embolism. That's why we got some special scores to rule out. That is Well score and revised Geneva score. So Well score is widely used for pulmonary embolism in most of the institutes, and we know that it is there for DVT and pulmonary embolism. So here we will see only for pulmonary embolism. All the scores are same. Clinical symptom of DVT, pulmonary embolism is most likely diagnosis are given more points with heart rate more than 100, immobilization for more than 3 days or surgery in the previous 4 weeks, and prior DVT, hemoptysis, cancer. All these are given. And simple, more than 4 it is likely, and less than 4 it is unlikely. Or you go with the revised Geneva score. It is also kind of including age, which was not there in Wells. So age is a new thing. Prior DVT, PE, and new things are surgery under GA, or there is a fracture of lower limb within 1 month is also added as a high risk factor. And active cancer, unilateral lower limb pain, that is DVT symptoms, hemoptysis, and one more important thing, heart rate 75 to 94 is also considered here and given 3 points, but heart rate more than 95 is given 5 points. So this revised Geneva score have extra of age and heart rate of 75 to 94 is mentioned, with general anesthesia being a risk factor and fracture being a risk factor. So you can use any scores you want, but revised Geneva is like very easier and better compared to Wells because they have added many new criteria. And low is 0 to 3, intermediate is 4 to 10, and high is more than 11. So there is a probability, but still this two scores only alone doesn't rule out pulmonary embolism. They just tell that pulmonary embolism is a most probable diagnosis or not. Risk is there or not. But to rule out any patient coming with ER and you're suspecting PE, you have to rule out by using a PERC criteria, which is very new now. That is pulmonary embolism rule out criteria. So this is the new criteria that is added up in new guidelines. So what this guideline tells that all criteria should be met to tell that pulmonary embolism is excluded. So any of this is present, you can't rule out pulmonary embolism. So age less than 50 years, heart rate less than 100, oxyhemoglobin saturation more than 95, with no hemoptysis and no estrogen use, no prior DVT or PE, and no unilateral limb swelling, and no surgery or trauma requiring hospitalization prior 4 weeks. So all these 8 points should be negative to tell that you have ruled out pulmonary embolism, or else this guy is having pulmonary embolism risk even 1 is positive in this. So again, this PERC criteria is a new one, so that you don't miss out anyone. And as we know, once you suspect, what we do immediately is send a D-dimer. And you do now, you apply a PERC also, and PERC something is positive, still you doesn't rule out pulmonary embolism, you send a D-dimer. A new change in D-dimer has happened. What is the new change is, the standard D-dimer leads to over imaging. Okay, so the D-dimer cutoff we take is 500. It has ended up in over imaging. So we have taken something called age adjusted D-dimer. So what is this age adjusted D-dimer is? You just have a simple formula for those who have more than 50 years of age into 10. So more than 50, for example, someone is 60, 60 into 10, 600 is taken as the cutoff, not 500. So if someone is having D-dimer less than 600, doesn't need to worry much because it is normal for their age. Someone is 70, 700, 80, 800. So this criteria is something new which has been included in this guidelines, and this has shown that only less than 2% of embolisms were missed out. There is no much missing out of pulmonary embolism because of this new D-dimer criteria, and it has avoided over imaging in most of the cases. Just 660 years or 70 years, you go and do CTPA, you can avoid the money risk, the exposure to the CT radiation risk, and all the unnecessary investigations, and not just deviating from your diagnosis also will be helpful. And new thing, yours algorithm. This is not a new thing. This algorithm was there even before, but this was predominantly used during pregnancy. This guidelines, the yours algorithm. But now yours algorithm is considered for everyone, and it is very simple. Not to break your head with yours criteria. It has only three criteria. Sorry, like a Wells criteria. This has only three criteria. That is clinical sign of DVT is present or not. That includes unilateral limb swelling, unilateral leg pain, calf tenderness, all that signs being positive like Homan sign, and hemoptysis is a new sign. Pulmonary embolism is most likely diagnosis with symptoms of pulmonary embolism. So any one is present, you will take a cutoff of 500 for the D-dimer. No, you will take 1000 as the cutoff for D-dimer. Okay, so you can either take a age adjusted dose, or you can take this cutoffs also, you can use. So pregnancy adapted years criteria can safely avoid up to 65% of CTPA in first trimester. As I told, this was widely used in the pregnancy before, but now we are using it for this thing. So a major change in the diagnostic algorithm has been made. So simple, you are suspecting symptoms of pulmonary embolism, you will just do a examination and assess for the probability of acute pulmonary embolism. Quantify the clinical probability using either Wells score, or you will use the Geneva score. So they are the validated tools used in this guidelines. So the clinical probability is low. Like for example, the Geneva score is less than 4, it is the low. So the probability of pulmonary embolism is 15% here. But still, pulmonary embolism rule out criteria should be applied. That is the new change. If Wells is negative, if the Geneva's criteria is also negative, it doesn't mean that the patient doesn't have pulmonary embolism. Per criteria should be fulfilled. The 8 points, the classical 8 points should be negative. If so, then you can, no need to test also this patient, you can send them, or you can just go for the other diagnosis. There are so many causes for all those symptoms. Clinical probability is 15 to 50% if it is intermediate risk. For example, someone is having 4 to 11 in the Geneva score. They are the intermediate risk people. Here again, no need to apply the per criteria because already risk is present. So you will there do D-dimer testing and assess the years criteria. So years criteria is 0. You will just do D-dimer as 1000 cutoff, and if years criteria is 0, you will take the cutoff of 500. and you will just see anything is positive, you will do the perform with the diagnostic imaging. If the things are negative, that is years 0 d dimer is less than 1000, years 1 and d dimer is less than 500, there is nothing to worry about it. You will just exclude pulmonary embolism and go. Clinical probability is very high. Don't wait for years, D dimer, everything. Directly go for the imaging, which was there in the previous guidelines also. So I will just want to mention you that what are the changes that has happened compared to before. So this was the previous guidelines diagnostic approach where Wells criteria was used. Even now Wells criteria is preferred. Here they took more than 6%, 6 as high chance, 2 to 6 as intermediate chance, less than 2 you no need to screen also in them. So but now we are not ruling, leaving those less than 2 people also, we are using PERC to rule out pulmonary embolism. But here if there's more than 6%, 6 is there, directly we will go to CTPA. As I mentioned now, even now when there is high risk for pulmonary embolism, we directly do CTPA. If it is positive or negative, that is different. If it was inconclusive, EQ scan was done, which is now not preferred, which will be discussed later. This is completely cancelled now. Next is D-dimer. Those who have T to 2 to 6 intermediate risk, only D-dimer was used before, but now we prefer wells with D-dimer. Sorry, not wells, sorry. It is years with D-dimer. So years with D-dimer is used as a criteria now. So this also is cancelled now. So again, this inconclusive going to VQ scan is also cancelled now. So much of changes have happened. So that is why this pulmonary embolism guidelines is very important, because not one, two small changes have made. So much changes have happened. This is about the diagnostic algorithm. Next is diagnostic imaging. Remember, a positive CTPA is sufficient to diagnose PE. If negative CTPA, no need to go with the VQ scan. Nothing is going to help much. Okay, recommended in preference to a VQ scan to confirm diagnosis due to the higher detection of even the peripheral pulmonary embolism. So it has been proven superior compared to any other things. And one more important change I want to mention here is, before CTPA was standard, and if CTPA is inconclusive, we were going to VQ scan. Now they told it is not needed. So whenever it is contraindicated, we go with the alternative method. What is the contraindication we can expect? Someone who's very allergic to contrast, someone who's having severe renal issue, okay, and contrast can't be given in them. In those cases, you can consider VQ scan. In that, VQ SPECT is considered over planar VQ scan. Uh, just the 3D imaging and 2D imaging difference. So SPECT is a 3D imaging of VQ, so it is considered better than planar, and VQ scan is reasonable in preference to contrast MRI. Okay, and MRI again, it is not much preferred. If someone can't do a CT, go with a VQ. That's all. And pregnancy, low dose CTPA is reasonable over low dose perfusion scintigraphy. Very, very important. So low dose CTPA can be done in pregnancy. This is a new change that has happened, because before it was told that you can do a VQ scan, you can just catheterize the patient, give the um, radiating albumin, and then you can excrete the albumin faster from the bladder. But now low dose CTPA is considered better. So nothing to be worried. And very important, most of the centers I work or which I'm working are preferring this ultrasound and echocardiography so much for pulmonary embolism. Remember that the new guidelines tell there is no benefit of echo to look for RV dysfunction, to look for RVSP if it is raised, then consider. Okay, they are indicative, but doesn't mean that if it is negative, pulmonary embolism is ruled out. So acute PE will not show RV dysfunction is very, very important. So no need a echo for primary diagnosis. And when you suspect pulmonary embolism, you no need to sit and do see this Doppler of lower limbs. Why to delay the diagnosis? You suspect, you put all the perks criteria, D-dimer, everything is everything is suggestive with your symptoms. Go for CTPA directly instead of wasting your time, money, and patient also with the echo and Doppler, which is of no use. And this is after you diagnose, after you do imaging, and then you go with the new criteria. So this is again a very important criteria, that is risk stratification framework. Before, the risk stratification framework was very simple as that. So this was the stratification done. Simplified PESI score was used, that is pulmonary embolism severity index score, where there were age, chronic cardiopulmonary deformities, history of cancer with pulse rate more than 110, systolic BP less than 100, and saturation less than 90. So he with using this, and they classified acute pulmonary embolism into massive, submassive, non-massive. In massive, what happens is patient will be in shock with PESI more than 1. RV dysfunction was considered, BNP was considered, cardiac markers, mortality. So the mortality risk was high with the massive, and all these things were negative in non-massive, and the mortality risk was very less. So very simple: massive, submassive, and non-massive. This is no more used nowadays. So to easily classify the patient, to decide the site of care, to decide the form of care, and decide the management, it is important to classify them even better. That is why this A, B, C, D, E was made. So A is subclinical, means the patient was not clinically having pulmonary embolism symptoms and signs, but it was an incidental finding. Like, when we suspect some malignancy, we were doing CT and we suspected a something else in the patient and in the lung normality, and suddenly we found out a pulmonary embolism. This is an incidental finding, so it is considered as subclinical A. B is symptomatic, that but low clinical severity score. What are these clinical severity score? As I told, simplified PESI score is a very easy score, so that severity score is very low, and in imaging you found out it is subsegmental, single or multiple, but subsegmental it is B1. Non-subsegmental is considered as B2. Subsegmental means within the branches, okay, of pulmonary artery, but non-subsegmental means they're involving the main trunk also is possible, but they have low clinical severity score. C is symptomatic with elevated clinical severity score. The same PESI score is used. So here the echo comes into role. C is echo. C is cardiac. You can remember C for cardiac. C comes for echo. So C1 is normal RV and normal biomarkers. That is in echo normal RV, and in tropi your CPKMB and all those NT-pro, everything is normal. It is considered C1. Abnormal RV or more than one abnormal biomarker in tropi or CPKMB, anything is abnormal, or abnormal RV in echo, anything is C2. Both is there. That is abnormal RV and more than one abnormal biomarker, it is C3. So respiratory modifiers can be considered or not, that is up to you. So respiratory modifiers start with C, like saturation will be less than 90 with respiratory rate less than more than 30 with need of oxygen is there. D is we are going to cardiopulmonary failure. Okay, D is almost going towards death but not death. So D1 is transient hypotension, that is there was hypotension, you treated them with fluids, it became normal. Normotensive shock, a very important new definition of normotensive shock will be discussed further. So this normotensive shock is considered D2, and this people may have or may not have a respiratory modifier, like they will be requiring more than 6 liters of oxygen through the nasal cannula, or use of NRBM is needed. E is again cardiopulmonary failure, that is E1 is recurrent or persistent hypotension not getting treated with fluids or needing vasopressors and going into cardiogenic shock, and E2 is refractory cardiogenic shock with arrest. And here again hypoxemic respiratory failure which may need ventilator also will be possible in E. So very simple, A, B, C, D, E. As I told, A is asymptomatic, AA. B is symptomatic but low severity score. C is with severity score, C for cardiac, all the cardiac echo and the enzymes are involved in C. D is towards death. D for death, you remember, towards death but not dying. So D1 is transient hypertension and D2 is normotensive shock, sorry. And E is cardiopulmonary failure. And what happens in category A, B, subclinical low risk. So category A is again subclinical we told. Like for example, during cancer staging you found out, as I told. Category B is symptomatic but low risk. Here I would like to tell about this severity scores. So what is this PESI score is? Original PESI score was used. Here the age in years, male was given plus 10. Comorbidities like cancer is given 30. Heart failure. So each were given so many scores. And class was classified into like 65, 65 to 85 like this. But again, it is very, very, very difficult to do this in OPD basis or IPD basis. Anything, this score is very big. So now we have a modified simplified species score, which is very easy, most used clinically. So each variable is given 1 point. Age more than 80, cancer, chronic cardiopulmonary disease, pulse more than 110, systolic BP less than 100, SpO2 is less than 90, 0 low risk, more than 1 high risk. Very simple. And STR score is also used. Again, this is also more complicated. If want, you can remember. Any one positive in this STR score can be considered the patient needs admission. No means no need admission. So STR score is not much important in classifying the low risk. So simplified PESI score can be used widely. That's all. So B1 is subsegmental, single or multiple. B2 is segmental. As I told, subsegmental clot will be more peripheral. Non-subsegmental will be more towards the main trunk of pulmonary artery. And category C is very important. Here we have already told high risk, elevated risk. Don't go with other scores. Go with simplified PESI score, elevated risk if it is more than 1. That's all. If you want to remember, you can remember STI also is 1. PESI is 85. So once this is come, as I told, C for cardiac. So cardiac biomarkers, we will look for tropi, BNP and lactate. C1 it is normal. But any one is abnormal also, it is C2. And if it is abnormal with 2D echo findings, it is C3. So we have already simplified it. Role of lactate is very important. Measurement of venous and arterial lactate is recommended. Elevated lactate indicates subclinical end organ hyperperfusion and strongly correlates with early complications and mortality. Lactates are very important in pulmonary embolism. Again, echo findings or right ventricular dysfunction findings. Right ventricular dysfunction findings can be diagnosed with two forms. One is CTPA or echo. CTPA, if you have done immediately, you are smart enough to do it, then again your RV LV ratio will be more than 1 to tell that RV dysfunction is there. No, I have done echo directly. What are the other things? RV LV ratio here is 0.9 is the cutoff. Tricuspid annular plain systolic excursion. The M mode measurement less than 1.6 centimeter, indicating abnormal systolic excursion. McConnell sign, very famous sign, right ventricular wall hyperkinesia with apical sparing. Tricuspid regurgitation velocity more than 2.6 meter per second. RV dimension, again end diastolic diameter is more than 42 millimeter. And septal motion defect, paradoxical intraventricular septal motions. Coming to the D, towards death, D. So D is going to have incipient cardiac failure. As I told, T1 is transient hypotension, short-lived and respond to IV fluid. That means that there is no signs of reduced perfusion. They are not in shock. But normotensive shock is normal BP but isolated hypoperfusion is that there is shock but normal BP. So what is it? What is normotensive shock is? A normotensive shock is BP is maintained but lactate is more than 2 millimoles per liter. Acute kidney injury, that is urine output is less than 0.5 ml per kg per hour with cardiac index of less than 2.2 liters per minute per meter square. So normotensive shock is BP is normal but elevated lactate with a reduced urine output. And this is very, very, very important to tell that patient is a normotensive shock or not, because BP is not only the indicator in deciding a patient is going to die or not. Lactate, as I mentioned before, is very important with urine output, and cardiac index also can be considered. Category E is the cardiopulmonary failure. High risk for who needs immediate and aggressive intervention. As I told, E1 is going to be a recurrent or persistent hypotension with cardiogenic shock, and E2 is going to be a refractory cardiogenic shock, cardiac arrest without restoration with spontaneous restoration of spontaneous circulation even after 30 minutes. So these people will need for non-invasive or invasive ventilation will be there because they will be impending respiratory failure. And very important, this stratification is based on only these factors which were discussed now. Never on the size of the clot. Before there was something called modified Miller score, which tells that high absorption index based on the site of the clot. But now, absolutely, the thrombus size is not a factor at all. Now we have so many factors to decide that thrombus burden does not predict the outcome. And also, it will not tell you about the reperfusion therapy. That's all. So 2026 clinical decision pathway is that you will suspect and detect. You have so many criterias, Geneva criteria, Wells criteria, followed by perks to rule out, and age-adjusted D-dimer or years D-dimer can be used. Image precisely, CTBA preferred in all conditions now. This stratify to A to E. There is no non-massive, massive, submassive anymore, and you can decide on whether the patient needs a home or outpatient management or monitoring and escalating with a pulmonary embolism resuscitation team. So these are the new guidelines for the decision and pathway.